Welcome to our Primetime Alive program. Continence depends on you. I am Vicki Newell. I manage the Primetime Alive program at Mary Greeley. I always like to remind everyone, if you want to sign up for a program, join Primetime Alive, or watch one of our past recorded programs, you can get that at our website at mgmc.org/PTA. Our presenter today is Gretchen Young. Gretchen has been a physical therapist for 35 years and has been treating patients with pelvic floor dysfunction for more than 30 years. She enjoys quilting and crafting and spending time with her 7 grandchildren. Please welcome Gretchen.
Thank you for having me today. If I start talking too fast, just do this for me. That'll slow me down. So we're going to get right into this. What is incontinence? So you can read it. Incontinence is a lack of voluntary control over urination or defecation. So leaking, whether it's urine or fecal material. Who struggles with incontinence? I had a gentleman come and say, well, older people, they start to struggle with this. Well, it's not just older people. There are kids that have incontinence, middle-aged people that have incontinence, older adults have incontinence. So people of all ages. My talk today is going to focus on women, but it doesn't mean that some of the principles can't apply to men as well. So I pulled up this study from the National Health and Nutritional Examination Survey. It was done between the years of 2015 and 2018. Found that an estimated 61.8% of U.S. women, so there's that age range that they studied, 20 years old and older, had urinary incontinence. So that's 78 million women. So if you have incontinence, you are not alone. Why? What causes urinary incontinence? So there's a number of things I listed. This is not an exclusive list here, but hormonal changes can weaken the pelvic floor. So that can be from aging. We know hormonal changes come as we age, but it can be younger women too who have a hysterectomy or they have some ovaries removed that can change the hormone balance. Thyroid disease. There's lots of things that can change that hormonal balance. Childbirth. So sometimes you have kids that come really fast or you have big babies. They can cause a lot of tears. You can have not only tears to the soft tissue, but you can have traction to a nerve that supplies power and sensation to your pelvic floor. So childbirth, aging, and lots of things, not only hormonal changes, but think about as we age, whether it's joint pain, we get less active. When people stop walking, and we'll see later in the presentation, walking is so tied to strength of your pelvic floor, and you'll see a muscle that helps that pelvic floor work a little stronger. So you get inactive. That is part of that aging process. And I'm so glad you're all here because you're staying nice and active. So that inactivity can cause weakening of the pelvic floor. Obesity. So I'm considered obese. My BMI is over 25, but the more weight you gain, that can affect your incontinence. Chronic conditions. So there's some chronic conditions listed there. Those chronic conditions that I have listed affect the nerves. So remember, nerves are what sort of signals your muscles. So if it's not, you don't have that nice input to your muscles, they start to get weak. And then medications, I listed specifically the diuretics. Okay, they're gonna take that fluid off you and your bladder fills up faster and I've got to get to the bathroom more often. So medication, so the why. Treatment. Did I skip one? No. Okay, treatment. According to the Mayo Clinic, the first line of treatment includes, so bladder training. What does that bladder training mean? Well, if you are going to the bathroom really frequently, so every hour, I tell my patients, normal is about every 3 hours. But if you're going to the bathroom every hour, a bladder that's capable of holding this much now empties here. You have a muscle on top of that bladder. So every time you trained it to empty here, that muscle thinks, ding, 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 bladder's full. And then you put a cough or a sneeze or a bend or a lift on top of that and game over. Okay? So that bladder, you don't want to be going to the bathroom every hour. And people say, well, I go to the bathroom every hour because I'm leaking. Well, we're going to hopefully give you some tools to fix that. Okay? So bladder training, dietary changes. Biggest thing, caffeine. So in my intake, I'll ask patients, what are you drinking? How much water? What else do you drink? And if they tell me a Diet Coke, I tell them it's a double whammy because it's not only the caffeine, but it's the artificial sweetener. So those are my two big things that I tell patients, back off on that coffee. Now, I also tell my patients, I love coffee and I don't want to give it up. So I stick to 1 cup a day, but I tell my patients drink coffee and water at the same time frame, literally. Couple sips of coffee, couple sips of water, because that's going to dilute your urine. When your urine's diluted, it's not as irritating to your bladder. Okay, so think about that. And then because physical therapist, we're muscle experts, so muscle training, pelvic floor muscle training. So where are the pelvic floor muscles? Well, pelvic floor, so they're the bottom of your pelvis, okay? So there are a lot of them, and they create like a basin, all right? They're responsible for 3 main things, so they support everything that's sitting on top of them, including your bladder, okay? They control the outlets, so your urine coming out, your fecal material, stool coming out, and then for women, they control our vaginal opening. All right. And then sexual function. So everybody says, well, I'm doing my Kegels, right? Kegels, Kegels, Continence. It's an active contraction of your pelvic floor. The goal for doing them is to improve your control and strength. I will tell you when patients come to me, I would say about 50% are doing them correctly or incorrectly, however you want to phrase it. A lot of people, when they're trying to contract their pelvic floor, we can't see it, right? We don't know. So we're kicking in our butt muscles, we're kicking in our thigh muscles, we're kicking in our stomach muscles. And people, well, the problem is that's not contracting your pelvic floor, okay? So I tell my patients, think about you're in an elevator, all right? And somebody's right behind you. And you're about to pass gas and you don't want to. Those muscles that you use to keep from passing gas, that's part of your pelvic floor. Okay, so think about that analogy and it's smaller, right? It's not this big, huge contraction, but you'll be a little bit more on target if you think that way. Okay, so what is pelvic floor physical therapy? It's hands-on training of the pelvic floor muscles, which may include the use of vaginal probe and biofeedback, with or without electric stimulation. So it's hands-on. So people come for pelvic floor therapy, and a lot of times they're very surprised when I tell them, I'm going to look at your back motion, I'm going to look at your SI joint, I'm going to look at how your hips move, because that all, goes into pelvic floor, and they're thinking exercise, yeah, that makes sense. And then I say, and if it's okay with you, I'm going to glove up, and I'm going to have you take off your pants and your underwear. I'll let you drape 1 finger in the vaginal area. And they're like, oh, I wasn't expecting that. Well, that's how we assess the pelvic floor. Okay, so what we're going to do is we're going to see, hey, is there any restriction in those muscles? And then I'm going to see if you can do a Kegel correctly. And if you can't, I'm going to teach you how to do it. And then that gives me an idea, how strong are you? What's your endurance like of those muscles? Is there a lot of restriction? Is there pain preventing those muscles from working? And then we can tailor a program towards you. Okay, so hands-on. I did bring, so people say, what is the vaginal probe? Are you hearing me okay? Yeah, okay. So the vaginal probe, there are different sizes. The one we have looks like this. And the Mary Greeley Foundation has been very, very kind to purchase these for our patients so that they don't have to have the expense of this because insurance doesn't cover this. So that's very nice of them. So the vaginal probe is like a tampon and it has sensors around it. So when we interface it with biofeedback, we can see, number one, what's your pelvic floor doing when it's relaxed? Sometimes the pelvic floor is like this, and we got to work on relaxing it. Sometimes it's like it's not doing anything. So we use the biofeedback to help train the pelvic floor to contract better. And sometimes if there's really not good awareness, we might even do some electric stimulation, which is like, it's not painful. It's like a tingling sensation to those muscles and can actually get those muscles to contract. And what that does is sends a signal up your spinal cord to your brain, telling your brain that's where that muscle is. And then you work with electric stim. How often do we use these? I would say maybe 10% of my patients. So not very many people need this, but it's nice when you do need it. Okay? All right. Assist exercises. So we have our pelvic floor muscles, but then there are some muscles that assist the pelvic floor. So we have our adductor muscles. And we all use these instinctively because when we have to go to the bathroom, what do? Okay, so when we cross our legs, we're kicking in that adductor muscle and we're trying to get that muscle to help. What it does is it sends overflow to your pubic bone and then gets that pelvic floor to contract. So adductor muscles, we can use those, preferably not like this to the bathroom, but it's strengthening. Okay, and the obturator internus. It's one of my favorite muscles in the pelvic floor. A lady by the name of Janet Hume in the late 1990s was looking at the anatomy and said, why aren't we using this muscle in pelvic floor strengthening? So she did a research project, had fabulous results, got tons of grants. She started a program called Roll for Control, and we're going to watch a little video of how that obturator internus works. So I've had patients come and they contract their pelvic floor pretty good, but then we use the obturator internus and they're called assist exercises because they're helping the pelvic floor. And just like Janet's studies, she got like 50% better strength gains in half the time. And so I like to use these with my patients. And I'm going to teach you one of them today, but we're going to watch a little video. The video comes from Janet Hume. If you want to watch it twice, we can do that. All right. Was it not going to let me play it? Oh, here we go. Pretty sweet, huh? Okay, so ignore the slide real quick. We're going to do one of those assist exercises. So it's best if your feet can't be flat on the floor, scoop on your chair. Okay. Everybody see Katie? So your feet are going to be flat. You're going to put your feet in a V, but you're going to squeeze your heels together. So we're going to, yeah, about 45 degrees. Okay. So about 45 degrees. Squeeze your heels together like you're pinching a quarter between your heels. And then relax. Okay? Can you feel yourself go up off the chair? All right. That's not your glutes are working a little bit, but it's your obturator internus. And so if you actually sat on your hand or put your hand here, you would actually feel that pelvic floor come up off your hand. Okay, because that obturator internus is helping. So when we sneeze, I tell my patients this, when we sneeze, we're like this, right? But this pushes down on our bladder. So next time you sneeze, I want you to be up nice and tall. I want you to squeeze your heels together, okay? And contract your pelvic floor and then sneeze, because it's going to pinch off that urine flow. If you're a blaster, sneezes real loud, press here, because that diminishes your sneeze response. So squeeze your heels nice and tall, press here. Okay? I'll help decrease your leakage. All right. Strategies to reduce urinary urgency. So you have stress incontinence. So that's the weakness of the pelvic floor. So we were talking about that weakness and getting other muscles to help that pelvic floor. Urge incontinence is a different beast, okay? You can have a mixture, you can have a little weakness of your pelvic floor. The urge incontinence can be from that coffee. It can be stress in your life. Usually what happens is you were in a certain room in the house, a certain store, a certain activity, and you lost a bunch of urine enough to wet your underwear or maybe even your outer garments. Every time you get to that same activity or same spot in the house, same store, it's like there's a cascade of neuroresponses, and the bladder's like, oh no, I don't want to leak, I don't want to be embarrassed. And so your urgency increases, okay? That's what got me into pelvic floor therapy. So when I was 25 after my second kid, it was winter time. I went out to get the mail. I peed my pants before I could get back in. Every time I went to get the mail after that, I peed my pants. And I told my coworker, I was like, I am 25. I am peeing my pants. What is this? And she was just getting into pelvic floor therapy, and she said, you're going the next course with me. So this is the technique I learned, and it works. All right. So I'm doing something, maybe it's washing dishes, or maybe a certain phone call. Sometimes there's people that stress you out. Maybe it's that. And you're like, oh, I gotta go. So, and you're like, okay. So if you can sit down, all right. Once you're sitting, you're going to do some diaphragmatic breaths. All right. And people are like, what's diaphragmatic breaths? Don't overthink it. Put your hands here underneath your rib cage. Okay. You're going to take a breath, not through here, but through here. Let your stomach rise. And you're like, okay, I'm about to pee my pants. Are you seriously? That I want to take a deep breath. I know it sounds counterintuitive, but I promise you it works. Okay, ready? Usually by the second or third breath, that urgency has calmed down. Do a little contraction, your Kegel or Kegel, stand up. If the urge is completely gone, perfect. If it's lowered, walk slowly to the bathroom and get there. Time to take those pants down, okay? If you can do this enough, your brain sort of recognizes as soon as you start to breathe, it quiets everything down, okay? So diaphragmatic breathing is your friend. So that's that urge technique, okay? All right. Next one. Okay, so I gave you the first line of treatment. Now this is the second line of treatment, okay, according to the Mayo Clinic. So part of the second line of treatment is surgery. 1 in 4 women experience urinary incontinence within 8 years of undergoing mid-urethral sling surgery. So this is a bladder suspension surgery. So in 8 years, 1 in 4 women will get their incontinence back. So why would I put that in there? Because sometimes people will come to me and say, I think I'm going to have surgery. I don't want to waste your time. And I say, I don't want to waste your time. If you strengthen your pelvic floor and you still have surgery, the success of your surgery is better. Okay? Hopefully you won't be that 1 in 4. hopefully you'll be that other 3. All right, to keep your pelvic floor nice and strong. But just know that it's not a complete fix. It'll fail within 8 years for 1 in 4 people. Okay. And then medication. Medication is great too. A lot of people want a quick fix, but there's a lot of side effects with medication. I had a patient today, urge incontinence, was given oxybutynin a year ago, developed significant constipation because it dries you up, right? It takes that fluid out of your system. And she said the constipation was worse than the urge incontinence, and I had to stop it. And now I'm here because I need it fixed and I don't want to do it with medication. So, okay, I got some patient examples for you. So you can take notes if you want, or you can just listen. I tried to think about what are some common patients and what are some of their common complaints. So Molly is my number 1 patient, okay? She is 40 years old. She goes to the doctor and she complains at her annual physical, because a lot of us don't complain of it until our annual physical or until we're asked, right? That she has had more frequent urination during the day and sometimes can't get to the toilet in time. So that would be urge incontinence. All right. So she comes in to see me. And again, what does that look like? I'll ask some questions about your urinary, bowel. I'll test, like I said, your back, your SI joint, hip strength, and then look at your pelvic floor. So during the consult, she's telling me symptoms are getting worse over the last 5 years. She's a mother of 2 teenagers. The oldest just started driving. Okay, so can we say stress? All right. Her intake, she tells me she drinks 4 cups of coffee a day because she has to keep up with her 2 teenagers. And then voiding. Every 1 to 2 hours, she is peeing during the day. She gets up 2 times at night. She has 3 episodes of urinary incontinence or leakage a day, sometimes needing to change her underwear despite wearing a pad. Okay, so I do my physical exam. There's no tenderness of her pelvic floor muscles. If there was, we have techniques where we work on getting the better length to those muscles, because we know a tight muscle isn't a strong muscle, okay? It's an inefficient muscle. It can't go fully relaxed, fully contracted. So sometimes we'll work on that, but she has no tenderness of her pelvic floor muscles. She has average strength. So when I asked her to contract, I'm rating her at average strength. Good control, meaning when I say contract, she contracts. When I say relax, those muscles relax. That's not always the case, but in her case it is. So what's the treatment? The treatment is for urge incontinence. Number 1, I want to quiet the bladder with diaphragmatic breathing and quiet the pelvic floor. So what am I going to do? You got it, the diaphragmatic breathing. I'm going to tell her to decrease her caffeine intake, increase her water intake to dilute her urine, and make sure her bladder isn't getting irritated. And we're going to start working on increasing the time between going to the bathroom. Because remember, if you go too soon, you're training that bladder to empty, right? So average person for somebody like this, I would say 3 PT treatments. Okay, it's not that much. And I usually see a patient maybe once every 3 to 4 weeks. So it's not a huge time commitment. All right. So that's Molly. Okay. Naomi, patient number 2. Am I going too fast? No? Okay. 65-year-old female, complained to the doctor of increased number of urinary incontinence episodes a day, requiring 3 to 4 pads a day. So she's leaking a lot. Symptoms began about 2 to 3 years ago. All right. So she comes in for the consult. I'm looking at her back and her SI joint on her hips. She had a total knee 3 years ago, and pneumonia a year and a half ago with much coughing. All right. Her intake, she's already eliminated her coffee. She's already done that. She heard about that before from somebody, so she stopped her coffee. She's drinking about 4 water bottles a day, so she's getting plenty of water. She voids about every 2 hours, so not too bad, and only one time at night. So that's considered normal, okay? On the physical exam, she's got some mild tenderness of her pelvic floor, so there's some tightness there. Her strength is poor, okay? And you say, how do you test strength? Because when like the doctor tests your muscles, so here's how we do it, okay? Finger in the vaginal area. If I feel a little bit of muscle activity, you get a 1 out of 5 strength. If I feel a little bit more, 2 out of 5. If your muscles can start to lift my finger, 3 out of 5. If your muscles can lift my finger and I start feeling tissue close around my finger, 4 out of 5. If it's like a baby sucking on my finger, you get a 5 out of 5. Okay, that's how we grade the strength. So her strength is poor. She's about a 2 out of 5. Okay. And she's having difficulty isolating her pelvic floor, meaning she's kicking in her stomach, she's kicking in her butt muscle, she's kicking in her adductor, squeezing those knees together, everything she can do to get that pelvic floor to increase. Okay. So what's the treatment? The treatment is for stress incontinence. She is weak. So I'm going to work with her to better isolate her pelvic floor. Sometimes that's tapping the muscle, a lot of talking through it. I could use the biofeedback with the vaginal probe just to better connect the brain with those muscles. I could do some electric stimulation to get that muscle to contract a little stronger. Okay. And then I'm going to do the obturator turnus assist exercises. So heel squeezes, there's rollouts, there are standing plies, all designed to kick in your obturator turnus. And then when she gets a little bit stronger, there are some standing exercises, again, using a lot of hip external rotation, strengthening with my pelvic floor. Okay, so I'm working on. So what caused her incontinence in the first place? Probably her total knee surgery made her more sedentary. She got weak. She decreased her walking, didn't get back to it, and the pelvic floor started getting weak. Okay, and then the pneumonia on top, coughing a lot. She wasn't recruiting her pelvic floor with a cough, and the pelvic floor gave up. Okay, so that's Naomi. All right, now this is more of a difficult patient. Okay, Margaret. Oops. Go to Margaret here. Margaret, number 3. Okay, this is a 55-year-old female. Her complaints of the doctor are past urinary incontinence. Yeah, I've leaked for a while, not too bad, but now it's getting serious. Now I'm leaking stool, and I don't like that. It happens about 1 time a week. Okay, I can't get to the toilet fast enough, and I'm leaking stool. So she comes in. She tells me she had leakage of stool, started about 1 year ago. 2 years ago, she had her gallbladder removed. Okay, so now she's got a lot of GI upset. Okay, her stomach, digestion, it's just not working like it did. Okay, and then she's running to the bathroom, stool got softer, and now she's got more urgency and she can't get there in time. She's voiding urine about every 3 hours during the day and 1 time at night. So that's good for urine, but she's having 3 bowel movements a day. She's got maybe irritable bowel syndrome. Maybe she's just not emptying, when she has a bowel movement, so she has to go 3 times instead of 1 time. Intake, she's drinking 60 ounces of water. She's drinking plenty of water, only 1 cup of coffee, so her bladder's not too irritated. Urinary incontinence, she does need to change her underwear every once in a while, and she's unable to get to the toilet in time sometimes, especially for fecal. And if she sneezes, she's losing urine about 25% of the time with sneeze. Okay, so I test her pelvic floor strength, and it's pretty good. She's got good control, contracts when I want her to, relaxes, no tenderness of the pelvic floor. And it's like, oh, wow, what do we have to work on here? You're strong. So the treatment is for mixed stress and urge and fecal incontinence. So I'm going to start with that diaphragmatic breathing. Okay, I'm going to try to quiet things again. Now you say, It works for pee. Let me tell you, it works for fecal incontinence as well. Okay? So your colon's doing this, you start doing your diaphragmatic breathing, and it'll start doing more of this. All right? So do that same breathing to quiet things down. And then I tell my patients when you're sitting on the toilet to have a bowel movement, do the breathing then too. Relax your pelvic floor as much as you can to empty better. Okay? We're going to strengthen our pelvic floor. Okay? Probably more for endurance, all right, than for actual just 1 or 2 contractions. Okay, so I might have her hold her contraction up to 10 seconds. And I might have her do that multiple times a day. And I might have her do that contraction with a lunge, okay, or with a hip exercise, just to get a little bit more strength. Then, because she's having this for the last year, and she's going 3 times a day, and there's lack of control there, I want to know how good is your control. So there is a really great therapist I work with, Katie, who does a lot of GI problems. And so Katie has a technique it's called a balloon expulsion technique. And this will give Katie information on how well that control is. So as that stool comes down that large intestine, that descending area, and then it dumps into the rectum, how good is it keeping it from, once it gets to the rectum, holding it in or letting it in there in the first place? And if she sees something positive with that balloon test that she does in the clinic, then she does a more sophisticated test, and I'll let her talk about it in a little bit. Okay. And then I'm going to recommend a nutritional consult. Okay. She had that gallbladder out 2 years ago. She's having a lot of GI upset. What you eat is so important. Okay. So seeing a good nutritionist is so valuable. To getting that healthy gut and getting that firm stool again without being too firm. We can give some ideas. I have some handouts on soluble and insoluble fibers that I will give patients, but there's nothing like a good consult with a nutritionist. So that is Margaret. All right. Wow, I finished fairly early. You know what? I'm going to have Katie just tell you a little bit about what she does for her GI, and then be thinking of any questions, okay?
Let me give you this.
So my name is Katie Albrecht. I'm a physical therapist at Mary Greeley, and people who have pelvic floor muscle dysfunction, they don't all present with the same symptoms. You can have a diagnosis of pelvic floor dysfunction, and maybe for you that shows up as urine leakage. Maybe for the next person it shows up as sexual dysfunction. Maybe the next person it's constipation or difficulty emptying your bowels all the way. And so one of the things that I evaluate is how your pelvic floor muscles, how well they coordinate during a simulated defecation. So do your muscles relax like they are supposed to while you are pushing? And we know that about 50% of women who have chronic constipation, that their muscles are not coordinating very well. And so that's something that we can evaluate and look at and treat. In the case with folks who have a gallbladder out, sometimes we don't jump right to those kinds of tests. They sound really scary when I tell you what the tests are. And so people think, oh, and there's something else I could do. The first thing we always try is a fiber supplement. So when you have your gallbladder out, you tend to have a lot looser stool than you did before. It just speeds up motility. And so by adding a fiber supplement, we can bulk up your stool, make it more solid, and that gives you more warning. It gives a stretch to your rectum a lot earlier so that you know when it's time to go before it is too late. And things that are solid and bulked up don't sneak out. And so that is what we try first. And if that is not enough, then we can just keep digging. But that's what I would evaluate for. Did people think of questions? And pass the microphone around. It's a hard topic to ask questions about in a group, I understand, but it turns out it's happening to a lot of people, so don't be shy.
You can say my girlfriend.
Yeah. I mean, I think that's evident by the number of people here, right?
How does the SI joint, how does that affect the muscles?
So a number of ways. So if the SI joint is, for lack of a better term, malaligned, there's usually a muscle imbalance. When there's a muscle imbalance of the pelvic girdle, your two muscles specifically, but we'll say three. Your psoas muscle sits in front. It's a hip flexor. That's going to tighten up just to help stabilize. Your inner thigh muscles do, and your hip girdle, including your obturator internus. So we know that the obturator internus connects directly to our pelvic floor. So that the muscle imbalance can keep that pelvic floor from working like it should. The other thing, if you have SI joint problems and there's a lot of inflammation, your nerves that come off. So does everybody know where the SI joint is? So here to here. So it's like a triangle. So your sacrum is this part of your bottom of your spine. Ilium is here. So when you put your hands on your hips, you're really putting them on your ilium. Where those two bones meet is your SI joint. If there's a lot of inflammation, you have nerves that are coming off your sacrum. 3 of those nerve roots blend together to form your pudendal nerve, which supplies power to the pelvic floor. So there's ligaments that go off of there that can compress the pudendal nerve that affect the pelvic floor. So there's lots of things that play into your SI joint. And when your SI joint hurts, are you walking a lot? That's going to get you weak too. So that's why we look at the SI joint, because we want to know how level, what's the symmetry of your pelvis? Is there any pain there? And we're going to try to fix that in combination with your pelvic floor. You can't just treat the pelvic floor and forget everything else around it because they all play.
Is this subject in any way related to UTIs? I have several UTIs and I have leakage. Are they connected at all?
So I forgot to turn this on the first time. So UTIs, that urinary tract infection, yes, is going to, we know you have to empty sooner, right? So that's that bladder irritation. So that's going to tie into probably a little bit more leakage. I will tell you too that I've had patients in the past who were treated with UTIs. They came, they did their urinalysis and they're like, well, nothing's really showing up, but we're going to treat you anyway. Sometimes that pain that you think is because of a urinary tract infection can be due to your pelvic floor. So if your pelvic floor is really restricted and tight, it can sort of mimic those symptoms.
The only thing I would add is that sometimes if your muscles are not helping you empty your bladder very well, sometimes that just makes you a little bit more vulnerable to develop an infection.
Because, yeah, that urine sitting there and then giving you infection.
Embarrassing.
Can I get the microphone?
Oh, yeah. I'll be up there next.
Okay, here's my question. If you have prolapse of the bladder and the rectum, so how does that relate to incontinence? And do you have to have surgery first before, some of these treatments work, or what's the connection?
So that is a really good question. And I realized when I did the slides that I did not touch on that. So thank you for asking that question. So she's talking about a prolapse. What is a prolapse? If you think about the vagina like a tube, okay? And you have the walls, you have a front wall and you have a back wall. When your pelvic floor gets weak, or if there's an injury or a combination, what happens is that bladder starts to bow in the front wall and the rectum starts to bow in the back wall. If you have that heaviness, okay, something's coming out, you can also have a central prolapse too. So all of those can cause like a heaviness. But to empty, especially with defecation, pooping, sometimes people will splint. They'll put their hand sort of in the vaginal area, push that back wall to reinforce it. So pelvic floor strengthening helps get the rigidity back of that wall. Research, by the time you get to a grade 3 prolapse, so what is the grade? A 1 is a little bit, 2 is like when we asked you to bear down, we'll see like a bulge. 3, it's getting all the way to the entrance, and 4, the prolapse is going outside the entrance. Research says that by the time you get to a grade 3, pelvic floor strengthening isn't very good to reverse that. Grade 1 and 2, pelvic floor strengthening, good evidence that it reverses it. But I will tell you, I've had patients in the past with a grade 3 that were able to reverse to a grade 2 with strengthening.
And I will say too, I'm like the data queen of the team. There is actually some pretty decent data looking at symptom relief with pelvic floor muscle strengthening.
You know what? I just got thinking, will you talk on her microphone because
Sorry.
the people at home may not be able to hear you.
So there is some data that if you do pelvic floor muscle strengthening with a prolapse, even if it's a grade 3, that you can have really good symptom relief without reversing the prolapse. So the prolapse may not actually reduce, but you are able to go without symptom if you are doing the exercise. That is newer data from it doesn't feel that new anymore. It's 2011. I guess that's not really that new anymore. It was really exciting when it happened. So she's right that once it gets beyond a certain point, we may not be able to change the actual prolapse, but if we can make it so that it's not symptomatic, that's really what matters.
I have another question.
Yeah, I think I'm Molly, Naomi Margaret. You need to put a number 4 for an 85-year-old woman in there. You say you need to empty your bladder. Well, I don't have a sensation because it just goes on its own. But when I do go to the bathroom, think I've emptied it. If I stand up, obviously I didn't empty, it just leaks again.
So remember, you have the muscle around your bladder, and that's helping squeeze the bladder to empty it. That detrusor muscle can get weak because of some other problems, like we saw, like musculosclerosis can do it. Sometimes the Parkinson's, sometimes the diabetes. Sometimes it's positional. So prolapse, if you're prolapsed and that bladder is pushing or descending a little bit, and there's a kink in the bladder neck, sometimes that keeps you from emptying all the way. So what I usually tell my patients, first of all, is when you're going in the bathroom, you can try a different position, tilt your pelvis a little bit one way and then the other and see if you can empty better. Sometimes people will push a little bit on the lower abdomen to create a little bit more pressure on their bladder to empty. Sometimes you need to stand and sit down, and sometimes that changes that bladder neck to get you to empty better. So I would try those. Any other thoughts?
I love all of those.
Oh, okay.
I'm not sure if this is connected in any way, but this has happened to me twice, and this is extremely embarrassing. But anyway, I've had COVID twice, and I had it very severely. And I coughed so hard that I had to put my hand down there. And because of that, it went into my hemorrhoids and caused them all kinds of issues too. And I'm allergic to lanolin, and so I'm in another situation. And I just wonder, is there any connection with that pressure there?
So when you're talking about the rectal area?
Right.
Okay. Well, Katie can probably speak to this more, but I will say if it's more of a prolapse from the vaginal area, but I'd probably still try it in the rectal area. If you can lay on your back with your knees bent and get some pillows right underneath your butt to put your pelvis on an incline and get gravity to pull everything off. I usually have my patients do it for like 5 minutes, 2 or 3 times a day, just to take that descending tissue and pull it back up and in. And then in that position after 5 minutes, I usually have them do some pelvic floor strengthening while they're in that position, but yes.
Yes. If you have, I want to make sure I'm understanding this correctly without asking you questions that might embarrass you further. Are you talking about, like prolapse in the vagina, or are you talking about a prolapse that's coming out of the anal opening?
It's all strictly down in there.
So do you have a prolapse or did you just have an urgency?
I just was coughing so hard that the
Yes.
pain
Yeah.
was shooting in.
And then it
Oh,
was
pain,
a
got
rectal.
it.
So,
Yeah.
and then it went down, down and followed it on down.
Yeah, coughing is terrible. I mean, we see a lot of people who have chronic bronchitis, and certainly with COVID, it causes so much stress to those tissues that not only can you experience prolapse, like the stress causes weakening of the tissue, but sometimes that chronic stress on that tissue causes pain. And then all of it is hurting,
Because I'm fine, otherwise I don't have that
Absolutely.
problem.
just when you're coughing.
Coughing that hard. Yeah.
And one of the things that I like to share with people, again, I'm the data queen. There was a study in the mid-90s at the University of Iowa where they looked at all of the female collegiate athletes. And they asked them questions about urine leakage. And they were really looking for things like what kind of sports caused more leakage. But they happened to have a question in their questionnaire about, do you ever leak urine outside the context of your sport with, coughing or vomiting or something like that? 25% of these women were leaking urine outside the context of their sport. These were women who were 18, 19 years old, never had a baby, best shape of their life, and a quarter of them are leaking when they get bronchitis or if they're vomiting. And what we drew from that was that our continence mechanism, there's a threshold. There are some things beyond which it doesn't matter how strong your muscles are. If there is enough downward pressure, you will leak. And sometimes really bad coughing from an illness is one of those things.
But then strengthening once that cough is gone.
I hear so many different opinions about this, but how much liquid should an average person drink during a day, whether it's milk, water, booze, whatever? But I mean, liquid.
So it's recommended, I don't think it's changed, Katie can correct me, but 48 to 64 ounces of water. Remember that your alcohol is going to be a bladder irritant, your caffeine is going to be a bladder irritant, and your artificial sweeteners are going to be a bladder irritant. So sometimes people say, yeah, I'm drinking a lot. I'm like, well, how much of that is water? 2 cups? Well, that's not enough. So you got to quit your other stuff and get a little bit more water.
Okay, so 40 water.
So I would say 48 to 64 ounces. That's what I tell my,
Yikes, okay.
yeah,
Well, that's 6 to 8 cups, right?
you got it.
6 to 8.
So some of your water bottles are 12 ounces. So that's already a cup and a half. So
Is there any benefit, I've heard one time too, when you're urinating to squeeze and stop the flow and then start again? Is that good or bad or harmful, or is there?
thank you for asking that. So if you want to do it just to see every once in a while, like maybe once a month, I'm okay with that, but do not do that as an exercise, because what you're doing is you're not letting your bladder empty and you're setting yourself up for a urinary tract infection. Yeah, so don't do it as an exercise.
Did they used to teach that?
They did.
I was just
They
gonna say,
did.
I'm sure.
We
I gotta
had-
go back, and if we have a video with that in it.
We had to reteach patients that all the time. I think they stopped, but years ago, doctors would tell, yeah, just do that. I'm like, no, please don't do that.
Okay, interesting.
if you're having problems drinking enough during the day, I have found that every time I see a faucet, I take a cup and I drink a cup. So that way I get my quantum throughout the day.
That's a good idea. I just thought of something too. My patients that have a lot of leg swelling, what I usually tell them is an hour before bed, lay down, get your legs elevated higher than your heart for about 15, 20 minutes, and then get up and do your normal bedtime routine. Because what you're doing is you're allowing your body to take that fluid off your legs, get it to your bladder, empty, and sometimes you can knock out one of those nighttime voids and you'll sleep better.
Well, I think everybody likes that suggestion. Wow.
What is the acceptable number of times that, the acceptable number that you could pee during the night?
Well, they'll say normal is 1 time, 0 to 1 time. So when it gets 2 or more, you know, we don't like that. And why don't we like that? We know sleep is so good for overall health. You start not sleeping, you're waking up too often, and that's going to play with your nervous system and lots of other things. So
what tips do you have to not go during the, I mean,
so again, if you have leg swelling, that's one tip.
yeah.
I you can decrease your water intake after supper. You know, if you want to go to like sips after supper so that you're not getting so much that your bladder's filling up.
I think Katie did a program for us because I used to be 2 and 3 times. And I think you told us if you wake up to do Kegels while you lay there in bed. And it's amazing. It only takes a couple nights of doing that because that'll take the urgency away and then fall back asleep.
That freeze and squeeze technique that Gretchen had on her slide.
Microphones.
That freeze and squeeze technique that Gretchen had on one of her slides where you do the breathing and then squeeze your muscles is a really good way to like, it just helps you ride out that urge. And sometimes the urge will just go away and you can fall back asleep.
I feel it's fine.
2 questions, actually. Talk to us about probiotics and prebiotics when you were talking about increasing the fiber. And then what about Imodium?
I can speak to that. So I am not an expert in prebiotics or probiotics. When I have people get a fiber supplement, I tell them to just get a generic fiber supplement. So generic Metamucil, generic Benefiber. It is the Metamucil is my favorite, the one with the psyllium fiber. That's the one that is the best bulking agent. People take prebiotics and probiotics for lots of different reasons. But just from a strict fiber standpoint, I stick with something cheap and accessible. Imodium is what folks take if they have diarrhea, if they're trying to slow motility. And it's over the counter, so I suppose that you are free to use that. One of the things that I like for people to really think about is whether they really need to slow their motility or whether they need to speed it up. Because one of the first signs of really bad constipation is fecal incontinence. And so you might think, oh, I'm leaking. I need to shut this off. I better take some Imodium. You might be leaking because that's all they can get out. And so talking with your healthcare provider about which direction you should go would probably be best.
Just finish. For cancer patients, that's all they ever tell the doctors.
You're right.
Say is just go get some Imodium.
Thank you. So if
your lecture today is helpful.
Yes, the Imodium is particularly helpful for people who have had cancer and radiation to the pelvis. In particular, if you've had uterine cancer, cervical cancer, any type of radiation to the pelvis, the Imodium, especially while you're doing radiation, hugely helpful.
I know we seem to be dealing with women's problems, but I get up 3-4 times a night. And I don't know if my bladder's shrinking or what's happening, but I don't get much sleep. Any comments?
So your tube that goes from your bladder out your body, the urethra, your prostate wraps around there. So you can have an enlarged prostate and then you're not emptying like you should. But I will tell you, I've had patients in the past who are men who they actually had tight pelvic floor. So it wasn't, they went through the exam, the doctor said, I think your prostate's fine, go to pelvic floor therapy. And it was a tight pelvic floor because the pelvic floor wraps around there and can mimic a prostatitis. So doing the diaphragmatic breathing, we have stretches we can give patients too that help stretch the pelvic floor. They are helpful as well.
And is that something you can just say, oh, try this? Or is it you're to that where you're 3 to 4 times a night and you're a man? Is that something when you go to the doctor, you need to be sharing that?
If it bothers you, and it sounds like it does, that's worth bringing up with your doctor.
And again, part of it, I mean, there's not only something medically there, but also your sleep is being broken up.
That's
all
right.
night
Even
long.
if it's not a life-threatening problem,
Right.
it is changing the quality of your life and sleep. That's
Sleep.
important.
Sleep is very important. Very important. Other questions?
Does additional weight put pressure on your bladder and your pelvic area and all of that?
That's correct. But again, sorry, data. The data tells us that you actually only need to lose about 5% of your body weight to have a change in continence. So if someone is telling you that you need to lose weight in order to be continent, you don't really need to lose very much for it to make a difference. I find that very encouraging.
All right. Any other questions? I don't see that we have any online. I think we've kind of opened up the topic. Please do not feel embarrassed to ask anything, or you can wait afterwards and talk too. I know some people aren't as comfortable asking, so hopefully Gretchen and Katie can hang around a little bit if you want to do that. Well, thank you so much. Wow, what a great presentation. Lots of really good information. Please fill out the evaluations and give us ideas for other topics and speakers. You can drop the evaluation off in the basket on your way out there in the back. As a reminder, our next program is next Wednesday, November 19th at Mary Greeley in Bessie Myers Auditorium, and it's on protecting your vision as you age. And then the very next day, Thursday, November 20th, so I'm really throwing you off, we're back down here. And well, and I don't even want to tell you because it's been full for a couple weeks, but I will tell you because you can sign up and watch virtually if you'd like. It's Smart Tech, Simple Talk, Understanding AI Without the Hype. And we have had a huge response. So we will probably have to do this program again. And then also a reminder, Tuesday, December 2nd, you should have all received a flyer at home if you're a current member, is our Primetime Alive annual holiday gathering out at the Gateway. Starts at 1 p.m., so that's different than our programs. We'll finish up about 3 p.m. And we have a great caroler quartet that will be singing for us. They're a lot of fun because besides Christmas time, they're a pirate quartet throughout the year. So I'm hoping they might sing us a pirate song or two as well to the Christmas selection, but they get up dressed beautifully. So we're looking forward to that. So once again, thank you everyone for joining us. Thank you, Gretchen and Katie. Appreciate you taking your time this afternoon to share such wonderful information, and have a great day.